Hello and welcome to the video. Today I'm going to be talking about understanding oxygenation in terms of the pathophysiology and clinical application. So let's start right at the beginning. Fundamentally, at the most basic level, to keep humans alive, air must go in and out and blood must go round and round. We've talked about what happens when blood goes round and round in the previous video on the cardiorenal axis, which you can check out using the link in the description below. But today we'll be focusing on what happens in the part where air goes in and out. The purpose of breathing in is to be able to draw air in through the lungs to be able to extract the oxygen, which makes up about 21% of the air, into the blood so it can bind to hemoglobin, where it can be transported around the body and delivered to cells, where the oxygen can then be used for aerobic metabolism to produce adenosine triphosphate, or ATP, which is an important mediator for various physiological processes to keep the body running. As a waste product of aerobic respiration, we produce carbon dioxide, which then has to exit the blood into the lungs and is a waste product that we breathe out in exhalation. We are able to shift air in and out of our lungs by changing the volume of our thoracic cavity. Volume is inversely proportional to pressure, and so when we contract our diaphragm as shown here, it moves downwards, which leads to an increase in the thoracic volume and therefore a decrease in the intrathoracic pressure. The creation of a negative intrathoracic pressure therefore draws air into the lungs, and when we breathe out, the diaphragm moves back up as it relaxes, decreasing the intrathoracic volume and therefore creating a positive intrathoracic pressure, which pushes the air out of the lungs and leads to air being breathed out. The movement of the diaphragm contributes the most to changes in intrathoracic volume, but of course we have accessory muscles that we can also use to try and further increase the intrathoracic cavity to lead to an increased volume of air being breathed in, and there will be natural recoil of the chest wall, which leads to air being breathed out. So in order to get air, or more specifically oxygen, all the way to the level of the alveoli to be extracted into the blood, the air must go through the entire respiratory tract, which starts off with the nasal and oral passages into the pharynx, into the larynx, through the trachea to the level of the carina, where it splits into two main bronchi, several other smaller levels of bronchi, and then bronchioles, and finally alveoli, of which a stylized diagram is shown here. The oxygen then goes through the respiratory epithelium and into the capillaries or the bloodstream as shown here, noting that there can be an increase in this interstitial space between the respiratory epithelium and the blood in pathological states. The blood then all goes from this pulmonary circulation back into the left side of the heart, where it is then circulated around the rest of the body through the systemic circulation, where oxygen is delivered to the tissues for aerobic respiration. The byproduct of that is carbon dioxide, which then goes from the bloodstream in the pulmonary circulation out back into the alveoli, as shown here, and that carbon dioxide then exits the lung, going through the reverse series as described of the respiratory tract all the way out until it is exhaled. Respiratory failure occurs when there is a breakdown in this respiratory system, and there are two main ways this can occur. Type 1 respiratory failure is when there is an oxygen extraction defect, where there is essentially a problem somewhere within the respiratory tract, which can go all the way down to the level of the respiratory epithelium and the interstitial space, which therefore leads to a reduced ability of oxygen to be passed into the blood, and therefore less oxygen in the blood. The primary problem in type 1 respiratory failure is hypoxia, or low oxygen levels within the blood, for which the definition is an arterial pressure of oxygen of less than 60 millimeters of mercury in the blood. The other major type of respiratory failure is type 2 respiratory failure, or hypercapnic respiratory failure, where the problem is not so much oxygen extraction, but more so a problem with the actual ventilation process, where either there is hypoventilation because of either diaphragmatic or other respiratory muscle weakness, or some pathological restriction of the thoracic cavity, which prevents it from fully expanding and therefore reducing the ability to exhale and therefore leading to retention of carbon dioxide, or hypercapnia, which is the hallmark of type 2 respiratory failure, and defined by a partial pressure of arterial carbon dioxide of more than 50 millimeters of mercury. And because there is a ventilation problem and you can't breathe out, it follows that your inhalation is suboptimal as well. And so in type 2 respiratory failure, the partial pressure of arterial oxygen is less than 60 millimeters of mercury. So to summarize, type 1 or hypoxic respiratory failure is a oxygen extraction problem where there's a defect somewhere along the respiratory tract, which leads to a decreased amount of oxygen getting to the blood and therefore a low PaO2 of less than 60 millimeters of mercury. But because the ventilation mechanics are still relatively normal, there is still a normal exhalation process and carbon dioxide is able to be exhaled, and the levels of PaCO2 remains normal around 40 millimeters of mercury. In contrast, in type 2 respiratory failure or hypercapnic respiratory failure, there is a ventilation problem and therefore there's an inability or decreased ability to exhale carbon dioxide, leading to a retention of carbon dioxide in the blood and a high PaCO2 of usually more than 50 millimeters of mercury. And by definition, if there's a problem with breathing out, there's usually also a problem with breathing in, and therefore the oxygen levels are usually also low, so there's a degree of hypoxia associated with the hypercapnia, with a PaO2 of less than 60 millimeters of mercury. So now let's focus on type 1 or hypoxic respiratory failure and look at what are the possible ways we can detect it and where the possible pathologies can be that can lead to a defect in oxygen extraction. Conceptually, the fraction of inspired oxygen, which is 21% in room air, gets to the alveoli to make up the alveolar pressure of oxygen, which then is extracted through the respiratory epithelium to form the arterial pressure of oxygen. Now we can assess how well oxygen is being extracted from the alveoli into the arterial circulation by looking at something called the alveolar arterial gradient, or AA gradient, which is essentially the alveolar oxygen pressure minus the arterial oxygen pressure. In a perfect system where all the oxygen that's breathed in gets to the alveoli and all of that is extracted into the blood, we would expect an AA gradient of essentially nothing or 0. But in pathological states where there's relatively less oxygen extraction and therefore less PaO2, we therefore expect the AA gradient to then increase, because more oxygen is staying at the level of the alveolar and less of that's being extracted into the blood. Now we can directly measure the oxygen pressure in the artery by doing an arterial blood gas. But how do we work out what the alveolar pressure of oxygen is? This leads us to the alveolar gas equation, which is shown here. So the amount of oxygen that gets to the alveoli depends on the amount of air that is breathed into the alveoli, of which the gas pressures are determined by the atmospheric pressure, which has to be subtracted from the water vapor pressure, because of course we breathe in some water vapor as well with the air, which does not contain any oxygen. And of course we then have to multiply the amount of air we breathe in by the fraction of inspired oxygen, because only that amount of the air is actually oxygen, which is 21% in room air. We then have to subtract away the amount of carbon dioxide which takes up space in the alveoli, and that amount that's being produced is determined by dividing by the respiratory quotient, which is essentially a ratio of the amount of carbon dioxide that is released divided by the amount of oxygen that is consumed in respiration. And so if there is increased amount of carbon dioxide in the alveoli, there will be reduced space for oxygen to be in the alveoli. If we then put in some numbers into the equation, which are standard numbers like 21% FiO2, 760 millimeters of mercury atmospheric pressure, and 47 millimeters of mercury of water vapor pressure, as well as a respiratory quotient of 0.8, and so if you divide by 0.8, it's the same as multiplying by 1.25. We then can simplify this equation to this final equation shown here, where you can see that you can determine the alveolar oxygen pressure simply by getting the carbon dioxide arterial pressure, which you can obtain from an arterial blood gas, and calculating the rest in this equation. And so in normal circumstances where an expected PaCO2 is 40, you can see that PaCO2 of 40 times 1.25 is 50, and 150 minus 50 gives you a PaO2 of 100. There is another rule that is good to use, and that is that an expected PaO2 is usually 5 times the FiO2. And using this rule, we can see that if someone is on room air with 21% FiO2, the expected PaO2 is around 100 to 105. And so let's just round it to 100. And you can therefore then calculate a normal AA gradient in sort of an idealized perfect system to be pretty much 0, because your PA alveolar O2 will be 100, and you subtract away your PA or arterial O2, which is also about 100, using our estimate there. And so your AA gradient in normal circumstances is very low, usually less than 10, but in a perfect system, as we've calculated, pretty much 0. So you can see how a blood gas can be important to determine if there is respiratory failure, specifically hypoxic respiratory failure, because we can get a PaCO2 to calculate the alveolar oxygen, and we also get a arterial oxygen level, and so we can then calculate the AA gradient from a single blood gas, which will allow us to determine if the gradient is increased more than 10 millimeters of mercury, which will therefore suggest that the patient has an oxygen extraction defect and help narrow the differential diagnosis to respiratory tract defects causing hypoxia. Now, you don't always need to have an arterial blood gas to diagnose hypoxia, although this is the gold standard, because we have a neat tool that we use every day in clinical practice called a pulse oximeter. This works on the principle that deoxyhemoglobin and oxyhemoglobin have different absorption curves, as shown here, such that deoxyhemoglobin absorbs better at the red wavelength and oxyhemoglobin absorbs better at an infrared wavelength. Thus, When you use a pulse oximeter on a patient's finger, the pulse oximeter emits two wavelengths of light at the red and infrared wavelength, and this is absorbed by a certain proportion of deoxy and oxyhemoglobin in the blood, and the remaining that is not absorbed is then detected on the other end of the pulse oximeter. This is then able to calculate the amount of oxyhemoglobin and deoxyhemoglobin and a final calculated oxygen saturation, known as the SpO2, or the peripheral saturation of oxygen. Under most circumstances, the SpO2 is supposed to be equal to the SaO2, or the arterial saturation of oxygen. Some situations where a pulse oximeter may be inaccurate are when there is something blocking the route of the light, for example nail polish, or when there's poor peripheral circulation where there's not a reliable amount of blood getting to the finger for accurate detection. The pulse oximeter reading as a percentage, or the SpO2, which in most circumstances is the same as the SaO2, correlates with the PaO2, or the partial pressure of oxygen in the arterial circulation, via this oxygen hemoglobin dissociation curve as shown here. Importantly, an oxygen saturation of around 90% correlates with a PaO2 of around 60 millimeters of mercury, which happens to be at this point here, just before we go into the steep portion of the curve. This is significant because, as we've mentioned, the definition for hypoxic respiratory failure is that of a PaO2 that is less than 60 millimeters of mercury. And so, instead of doing a blood gas on every patient, we can just do a pulse oximeter reading, and if the patient has an oxygen saturation of less than 90%, which correlates to less than 60 millimeters of mercury, we can then infer that the patient has hypoxic respiratory failure. It's also important to note that the steepest part of the curve where it drops off is usually just below 90%. And so when patients are at risk of deterioration, it is not a good idea to over-oxygenate them and keep them high toward the right on this curve, where they will be saturating in the high 90s close to 100%, because it may take a significant amount of respiratory deterioration in order to actually pick up any drop in the oxygen saturation. In contrast, if patients are hypoxic and require supplementary oxygen, it is optimal to keep them at a range of around 88 to 92%, or even 90 to 94%, because if the patients were to deteriorate, you would see that their oxygen saturation would drop off a lot quicker, and this would be a lot more easily detectable on pulse oximetry, and therefore earlier intervention or escalation of therapy can be initiated. And that brings us to the end of the video. I hope you now have a better understanding of oxygenation in terms of the underlying physiology, the definitions for type 1 and 2 respiratory failure, and important concepts such as the alveolar gas equation, the AA gradient, and the oxygen hemoglobin dissociation curve, and the respective clinical applications. In the next video, we will look at the various causes of type 1 and 2 respiratory failure and give a practical approach on how to manage these in terms of using different modalities of ventilation. Here is a slide of take-home messages that we've discussed throughout this video for your review. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.